We'll start off, since quality is such an interesting topic, I think we have to add in some other things like geopolitics. And so this year is the 160th year anniversary of what conflict? Anybody know? It's relative to recent events in the Eastern Europe. Crimean War, excellent. So quality improvement in healthcare actually got its beginning, some people will give its beginning, to the Crimean War, where Florence Nightingale was a nurse, and she worked with the folks that were injured. Initially, at the beginning of the Crimean War, the loss in the war hospitals was around 60%, the mortality of being a patient in a war hospital in the Crimean War was around 60%. And at that time, kind of the understanding of germs was just starting, and she introduced a lot of different hygiene things into surgery and patient care that by the end of the Crimean War, they had about a 1% mortality loss with treatments. So 2 lessons from that is that if you don't learn from the past, we will repeat them, as we're now seeing in Crimea. And the second thing to learn is if you want something done, you get a nurse working on it. So take that home. How do we change our culture and manage change in our practice? In an organized way in the United States, we started to see a big shift in how we address quality improvement with the release of the Institute of Medicine to Err is Human in the late 1999 and the end of the 90s. And this quote, I think, kind of sums up that whole statement. At least 44,000, as many as 98,000 Americans die each year due to medical error. These numbers exceed the 8th leading causes of death and suggest that more people die in a given year as a result of medical errors than from motor vehicle accidents, breast cancer, or AIDS. So this was a real wake-up call, preliminary to our institutions, to really look at these issues. And then we saw the Institute of Medicine release the Crossing the Quality Chasm, and this really pushed things to a whole new level. And the statement from that I really like is that problems in healthcare quality are serious and extensive. They occur in all delivery systems and all financing mechanisms. Americans bear a great deal of burden of harm because of these problems, a burden that is measured in lost lives, reduced functioning, and wasted resources. And collectively, these call for urgent action. And so some of the ways we've tried to quantify this and talk about it and develop ways that we can work on it, the Institute of Healthcare Improvement, the IHI, developed the Triple Aim, and I'm sure many of you have seen this in different things, but the idea that it is imperative that as we move forward, that we improve health outcomes, that we decrease cost, and that we improve the patient experience as we move forward. And I thought it was great in hearing from patient voices, because some of the frustrations that you heard there was because of poor systems. And I would say most of the frustration you heard there was poor systems and inappropriate expectations and inappropriate delivery of what needs to happen in a patient experience. Another way that this has been broken down, and I'm sure if you've done anything with the federal government at any point around healthcare, you can dream about these. So this is the Institute of Medicine's 6 aims, so that what we do is safe, that it's effective, that it's patient-centered, that it's efficient, that it's equitable, and that it's timely. And I'll come back to these a couple times. If nothing else, I want you to have these ingrained in your head as you think about everything that you do in your practice. Don Berwick, he's a pediatrician who went to work for CMS. His quote that I really like is that the quality of healthcare is defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And I think all of us can agree that this is who we want to be and how we want to practice in whatever aspect of health delivery that we're working on. So we have this idea of quality, and as we break it down more, we want to look at the 3 domains. So in whatever you're doing, you're going to have a structural domain, a process domain, and an outcomes domain. So a structured domain would be, what is the system that you're using to provide care? So I'm a social worker with a county health department, and I'm working on high-risk kids in my county. So that's the system or the structural piece that you're working with. So I'm a nurse in a gastroenterology office, and I help with intake and follow up on our chronic kids. And so the structure would be the clinic that you're working in, the processes that you have to do that. I'm sorry, the the actual physical pieces. The processes would be how you kind of work people through your structure. So as a social worker, that I get referrals from our WIC office, and that has a form, and they have a number that they call, and that's how it's happened. And then this is the expected response that I'm supposed to do to that. Or when a patient comes in for a procedure in my GI office, that I review what we're doing today, and we figure it out, and we make sure they're at the right place, the right time, check all the billing, and then we move them into the next area for the next person to take over. So we have processes, and then the outcomes are the measures, how we track what we're doing. So that I, at the end of the month, have to make a list of all the cases as a social worker that I did, and I send that up to my boss, or that in the clinic, we are following our billing, and we know our patients, and we're looking at the type of patients that are coming through. So those are the three domains that you look at. And then indicators is very important. And as healthcare providers and healthcare services, we work with indicators all the time. So especially like as in nursing, indicators are a huge part of what you do. And just, for example, your vital signs, those are indicators that we have chosen. So indicators just represent a bigger thing that we're trying to measure in a simple way. So a patient comes into your office, you get their temperature, you get their blood pressure, you get their heart rate, you take a look at them, see how they look, and you write that down. And so as we work through this, we're going to have to make the compromise that we choose indicators that match in some way what we're looking to measure, but aren't too cumbersome that they don't slow us down so much as we try to measure them. So what are some different types of quality problems that we have? So overuse, underuse, and misuse. And so as you guys work on issues in your practice, these are going to be the types of problems that you have. So an overuse problem would be that I prescribe too many antibiotics for viral colds that come into my office. That would be an overuse of something that is standard treatment but is used too much in a way that's inappropriate. Underuse would be that we don't capture recurrent asthma exacerbations well enough that I'm prescribing preventative steroids enough that we're not keeping them in control. So that would be an underuse quality issue. Misuse would be that we are not prescribing, or we're not giving drugs in an appropriate way on the floor in my hospital, so that it's easy to grab one medicine instead of the other, and we give the wrong medicine to a patient. So those are different types of quality issues. And so just want to come back. So as we look at these dimensions, we're looking for that we want to practice in a safe way, an effective way, a way that is very centered on the patients that we're seeing, that's timely, that's efficient, and that's equitable. So now we're going to start looking at our practices, looking at what we do. So I love when you talk to physicians especially, and you talk about their practices, this idea that I am doing everything awesome. This is going great. We're really doing a good job in my clinic, and we've got things all together. So I have this view that the child comes in and they're in distress and they're sad, and then they interact with me and my lovely staff, and I wish I was that good looking. And then when they leave, they, thumbs up, we did a good job, and they are very pleased that their parents brought them to interact with us, and now they're going home and they're exciting. So as we look at this, we want to make things better, so we have to start looking at what are the variables, what plays into what I do. And there's a lot of different kinds of direct effects in our practice, and as we look at the practice variables that affect outcome. So when we go from child with a problem to child who has either no or less of a problem, there's many things that play into that. So you've got the child's age, you have the type of family, the family structure, the way that family communicates. You have the gender of the child, which often can affect how they respond to things. The health status, so how sick were they, or what kind of other issues are going on from a health standpoint that could complicate what we're trying to do. And then care coordination, how am I going to interact with them, and how does my office interact with them as we move forward with things that child needs to have to be healthy. And so that would be complicated enough, but all of these things interact with each other. So you can see that the age of the child in a family can be different, can respond in a different way. So the building blocks of quality improvement are focusing on processes that we have both internal and external customers. So a child comes in and I think has an infection, and I want to take a look at their white count. I send them to my lab person, my phlebotomist, to draw their blood. That child has there's two customers in that setting. There's the child who's getting their lab drawn and the family, and then there's me, because I'm a customer of my phlebotomist. So there's two customers, both an external and an internal customer in that process. And then we have to use data. We have to use objective data as we move forward. So one thing I want to make very clear is that quality improvement is not patient satisfaction. That is not what we're talking about. And there was a great article that Jay Fenton wrote that was in the Annals of Internal Medicine, or Archives of Internal Medicine, where they actually looked at patient satisfaction reviews. And this is getting there's actually two big companies now in the United States that have grown. There's one in Chicago that is I think it was rated the fastest growing technology company this last year, that does nothing but these patient satisfaction things that they pass out when you leave the ER and when you leave the hospital. And so patient satisfaction is a fun thing that everybody loves looking at right now. But what they looked at is actually health outcomes. And so what they found, if you look at most satisfied patients compared to least satisfied, so at the ends of the bell curve, the folks that give you the 5 stars on your Google Internet search of you as a provider, and the folks that give you 1 star, the ones that were more satisfied incurred 8.8% more healthcare expenditures, spent 9.1% more on prescriptive drugs, and were 26 more likely to have died by the end of the year, 2 years out from the follow-up. So patient satisfaction and quality care is not the same thing. I just wanted to make that very clear. So just to show you that I am not just a spokesperson, I'm also a client. That's a bald joke. I brought my QI team, or most of my QI team. They're sitting up here at the front table. As we build a team for whatever setting you're in, and this is directed toward an ambulatory care setting, you've got to have the right people there. And a lot of times what ends up happening, and I think a lot with kind of how we've set up maintenance certification for physicians, you have one kind of quality champion that is a physician, and he or she does the little MOC project and then applies it to the practice. And as a nurse or as a staff person, you get it applied to you. But one of the key things is to develop a team for your practice. And so that would include physician providers, any advanced nursing practice, your nursing leaders, any IT support that you have for your practice, office staff, billing. It's nice to have a parent involved, but that is very, very hard. It's a challenge to do that. And often the folks that are the most useful, they just don't have the time, and the ones that do have the time aren't that useful, has been our experience. You want clear involvement of your clinic leadership, and this can be very hard, I think, especially in kind of larger institutional organizations, or if you're a part of an FQHC structure. It gets difficult. But the whole idea with that is you get all the players in place. And one of the hard things, I think, for advanced practice nurses or for physicians is that we like to get in, make the assessment, make the prescription, and then move on to the next thing. And you really have to be patient. You need to make sure that all members of your team are brought along so that everyone's a part of this. Because what's going to work best, the kinds of projects that are going to work best, is when the process change and even the measures that you're using are developed by your office. So if your nurse or your front office person is coming up with this, and I'll give you a great example. The very first project that we did when I came to my current practice was actually brought up by one of our telephone operators. So what we were seeing is that we were getting extremely bogged down in the afternoons. That people would call, the kids would be sick all night, they'd call in the morning, they'd get a call back about 10:30. By that time, our day was pretty full, and they would get an appointment at 4:30 or 5 o'clock, and so we were really dragging out the end of the day. And so I was coming in and being there till 7:30, 8 o'clock at night. And so one of our telephone staff said, why don't we just tell these people to come in? And so we sat down and talked about it, and we decided to have a walk-in clinic in the morning. So every morning during the week, Monday through Friday, we have from 8 to 9 o'clock, we have a walk-in clinic. It's for new acute things, first come, first serve. And it tremendously removed the pressure from the end of our day. So an idea that came by a staff person that felt comfortable to make a suggestion. So I encourage you to have a broad-based group, meet regularly, and there is no bad suggestions. So I want to give you some models, and all these are just framework to help you kind of work through these issues and give you some key terms that will help you talk about this as a practice and as you're trying to, because I think the important thing is that you have the words to express some of these ideas that you're going to use over and over and over again. So we'll kind of work through the model for improvement. This is from IHI. IHI.org is a great resource to just get some background information. Another great resource here in Tennessee is TIPQC, TIPQC.org, which is it's a perinatal quality initiative that has done some great work, and they have a lot of good resources on their website. And then Deanna has put together some of those for you as well. So the model for improvement is that what are we trying to accomplish? How will we know that change is an improvement? What change can we make that will result in improvement? And you guys are going to have a lot of that if you're doing MOC for this project. A lot of that's going to be specified for you as we go through this. What's going to be important is how do we do this PDSA cycle, the Plan, Do, Study, Act? And we'll talk about just some of the philosophies with that. So what are we trying to accomplish? That's your aim. And we want to use the quality indicators as safe, effective, patient-centered, efficient, equitable, and timely as we kind of look for opportunities in our practice. And I actually keep just a running list that is all the things that kind of come up that are either structural outcomes or measures issues that we're having in our practice, so that we have something to kind of go back and review. You want to prioritize these, so really talk about it, and that's the thing that takes time, because as you talk with your partners or your staff, everybody has to be bought in that this is a priority or your projects aren't going to work very well. As you move forward on a project, make sure your goals are not ambiguous, that you have very clearly defined goals and timelines as you move forward, and be very clear on the boundaries. Because a lot of these projects, as you start getting into data, they can drift all over the place. And so you want to be very clear about what we're trying to accomplish with this specific process change. Another thing that I found very helpful, this is from the Improvement Guide, which is a great book that Gerald Langley wrote, but change concepts. So if as you look at the 6 aims, if those aren't clear enough for you, change concepts is another tool that you can use as you look at your practices. So eliminating waste, improving workflow, optimizing inventory, which in pediatrics, that's all about keeping your vaccine inventory low. Change work environment, improve provider customer experience, improve time efficiencies, decrease variation in processes so that everyone is always doing the same thing. Mistake proofing, improve product services. And so I hope those of you who are doing care coordination and are involved in directly managing a lot of that, at this point you should be saying, you know what? I think every client interaction I have is a QI project, because this is what you're doing all the time. You're stepping in to systems that aren't working optimally, and you're problem solving around these areas with individual patients or clients all the time. Just for if you have trouble sleeping tonight after all the wonderful information you get today, this is the latest core set of children's health quality measures that Medicaid and CMS have put out. This is the latest one in 2014. So I would also encourage you, as you guys find things, if you're having trouble prioritizing projects, coming back to this and looking at what is the federal government looking at. And if you are well aligned with that, then you probably are pretty safe that you're doing something that's pretty important. What are we trying to accomplish? So as we talk about aim statements, and it's a little different from the aim that Deanna was using in the earlier presentation, but as you develop the aim of your projects, you really want to work on what's important, not what's sexy. And that is extremely hard, because guess what? About 36% of us as adults have ADD. We watch way too much TV. The things that come in, you're going to get, if you work in any kind of system that's more than just one physician and one nurse, you're going to be getting all kinds of things that pop up every day that someone is all fired up about, that we have to make sure we fix this and get excited about it. And you have to come back and look at those and say, is this just what's right now, or is this really what's important to what I'm trying to accomplish? And then steal shamelessly. One of the things that I have truly enjoyed, and one of the benefits of being president of TNAP the last 2 years, is that I got to go to a lot of practices and see what they're doing. And so I have stolen that. In fact, my office folks over here, especially Ella, who I'll let speak in just a second, she would, every time I said, I'm going to go up and visit these practices up in Johnson City, she'd be like, oh, great, because he's going to come back with some other ideas. So our aim is how good and by when. So as you guys think about doing kind of process change, I want you to put it down into these kind of finite terms. Even if it doesn't work and it wasn't realistic, it's extremely important that everything that you work on, that you have, what are we trying to do, how good do we want this to be, and what's our time frame? And that'll really help you from wandering all over the place with some of these interventions. So for example, if the problem was we were having a hard time getting patients in to see the doctor, it was taking forever, so the patient walks through the door and we've got a real long wait time, we want to work on that. A good aim statement would be Highland Pediatrics will decrease the mean registration to physician time by 20% in 18 months. So this is what, as we come to our meetings and we talk about the project, this is what we're coming back to. Highland Pediatrics will offer 3 possible well care visit times within 48 hours of parental request within the next 6 months. This was an actual project that we worked on where we were noticing that as we got into the summertime, well checks would sometimes be 4 and 5 and 6 weeks out, and school was starting and parents that wasn't acceptable. So we needed to find ways to change that. So those are just some examples that I put in there of what an aim statement looks like. Now, how do we know what we're doing will be an improvement? And so as you think about your practice, I want you to appreciate the difference in personality, because that can be an extremely frustrating thing, but you need to value that. And so you kind of have the two extremes. So you've got the guys who are jumping off the cliff over here, ready to go and do whatever at a moment's notice because it's exciting and it's new. They didn't take their Concerta that morning. And then you've got Waldorf and Statler from the Muppets, who are just going to say no to anything that comes up and then make fun of it as it goes along. And you actually need both of those people. You need that in an office. So what are the challenges as you guys kind of work on some of these projects? Well, guess what? If you're changing things and you're adding new stuff, it adds work. And you have to be realistic about that. And you want to make sure that you balance that. We talk about balance measures. That's the way that you actually measure, as an outcome measure, measure work. But we have to make sure you're doing that. The difficulty with accuracy and consistency, and that's one of the curmudgeons in your life will always come back to that with QI projects, that what we're trying to measure is silly. This has nothing to do with anything real. But at times you have to say, well, this is the best we can do. We know we need to work on this. This is the best measure we have. So that's what we've got to go with. Use the manual versus automated is really fun right now, trying to decide kind of how we're going to use our technology. How do we work with charts? A lot of times you have to be careful that the data that you're generating through these projects is going to be misused by management. Are they going to come back and because you've got an outlier in your practice, that person now is going to be in trouble with what's going on? I really want to stress that QI projects are not about kind of rooting out the bad players. It really is about improving your practice. Measured elements can be chosen inappropriately, so you have somebody that has an agenda that they want to prove something, and so they choose measures around a project that don't fit with what you're really trying to do. And then just lack of training. We're not data experts, and so sometimes it can be very difficult to kind of manage the data and know what it means as you go forward. The opportunities in all of this is that you can really develop over time a very healthy and more effective decision-making process. Because as you move forward and there is change and change is going to happen, you have a structure to deal with these things. We can sit down and we can think about where are the areas that this isn't working, how does this fit into things, how can we look at it, how can we measure it, what changes are we going to make and move forward. As you make progress, as you're not making progress, you actually have data to show that. You can look to that. It really builds confidence in everyone in your organization that you desire to make things better. So when problems come up, it's not a negative thing. It's an opportunity for change. So instead of a problem being something that like, who's going to get in trouble for that? A problem is something we need to take this to our quality improvement team to see how we can do it better. And then my favorite thing is that data sells ideas, and it really limits the power of that dramatic anecdote. And in our practice, we have some extremely reactive physicians, so much so that you can go home and your neck hurts at the end of the day. So the way that we operated when I first came into our practice was that something that only happened every 200 years would happen. And there would be this huge blow up about how this can never happen again. And guess what? It would take, an eclipse is going to happen before this happens again. And so now we have to burn the whole practice down and rebuild it again to make sure that one thing that was never ever going to happen again never happens again. And so if you have a way to address those kinds of issues, you can sit back and say, well, that sounds terrible. Let's get some data and let's look at how often is this really happening. And so it really smooths that down so you're not running around chasing the latest disaster that happened or the latest article that was in the paper that everyone's now worried about. So rules, the main thing I want to say is that QI is not to build a case to punish someone or to show that someone's not functioning well in your practice. It really is about looking for opportunities. I'm going to move it just a little bit here. So what change can we make that will result in improvement? So all improvement will result in change. All change will not result in improvement. And so as we look through this, it really is going to be kind of taking the time to analyze what you're doing, make sure what you're doing is evidence-based, that you have a good, solid science foundation for moving forward, review benchmarks, so look at folks that are performing well and see what they're doing. And that's the nice thing about being in systems sometimes is that you are actually getting those benchmarks and those are coming to you. Talk to folks that are experts in this, who've done it before. Really brainstorm, critically think, and do that in an organized way and take your time doing that. And then don't reinvent the wheel. The great thing with where we are with healthcare reform is a lot of very intelligent folks are thinking about these kinds of process change, especially as you look at the ones that CMS and the federal government is choosing. There's a lot of stuff out there. There's a great resource now called the National Improvement Partnership Network, which was funded through a CHIPRA grant at the University of Vermont, where they're actually collecting all of the big scale quality work that's being done in I think there's 24 states in it now. So there's a lot of great work so that you don't have to invent all that on your own. And then how do we analyze what we're doing, this kind of plan, do, study, act. So and this will be, you'll use this with process change. So Deanna's given you kind of 2 aim areas that you will work on if you're working on MOC with this. And as you get in there, there's going to be opportunities to change processes and to look at specific things in your practice that you're doing. And if you guys are in an affiliated network, I encourage you to share those process changes with other folks. Really look in your setting and say, how can we, the things that we're going to do in our office, if you're affiliated with other offices, how do we broaden that discussion over all of our affiliated offices so that we can start to bring that, all of this problem solving work we're doing, that we can share in that. And that's an important piece. A lot of times gets missed. Like I want to do a project around, so I'll give you an example of, we did one, just my nurse and I, on making sure that we were screening effectively for maternal depression in newborn. And so we were using the Edinburgh newborn depression screening with that. And so as we kind of worked on that, is how do you integrate that into your visit in a way that, moms already fill out 800 things. And we're talking about doing that at the 1 month and the 4 month visit. And a lot of times you've got older siblings who are 2 and 3 and they're running around and you're trying to, so how do you incorporate that? And so we had a lot of little process things that we had to develop along that, and we were sharing that and bouncing it off other folks that we knew were worried about the same thing, and that's extremely helpful, and make sure you're taking advantage of that. So as you develop your aim, we know what we're going to do, we know what our goals are, by when, we know how we're going to measure it, we know how we're going to apply it. Now we have to start kind of figuring out, like, now how are we going to do it? How's that going to play out in our office? What are the things that I'm going to ask my front office to do? What are the things I'm going to ask my nurse to do? What are the things that I'm going to expect myself to do? How are we going to structure it in the chart? So and those are all called process changes. So we're going to look at developing some little process change to address that. So we plan it, we do it, We kind of know what we think is going to happen. We study how that process change goes. So the metrics that you're given, you're starting to measure those. So you do your first initial data. So like in this project with the medical home, you do a 20 chart review, and a lot of times we'll do that, have a big kind of, where we'll go out and we'll look at some stuff, and then you come out of that, see where you're struggling, develop your process change, you implement it, and then you come back and you measure, in this case, 10 charts to look and see how you're doing. And so you work through that, and once you study it and get your data, then you have to act on that. So was that a dumb idea that we did? You know, that was not a good process change. So now we're going to either change it or back it up. So what we did in the newborn screening, so I was coming in at the 1-month visit and handing the Edinburgh screening tool to the mom. And while I was examining the child, she would fill it out. And then while we were talking, you know, I could grade it and then we would address it. And that seemed to work pretty well. But then my nurse said, well, why don't I just give it to her when I take them in the room? And so she would do that and they'd fill it out so it was there when I could check it off. Because a lot of times, you know, that's the thing that you don't want to find out at the end of the visit, you know, that this mom is struggling. You want to find out at the very beginning, and so you can spend all your time kind of focused on that. And that worked much better. So that was kind of the second iteration of that as we go along. So you get this change concept in addressing a problem. And that's kind of a theory. We think this will work. We test it. So we measure some data. We apply it. And then we come back, test it again, apply it. And eventually that gets universalized to whatever your practice setting is. And so a lot of the things you'll do, you'll kind of start a pilot project, or you'll start with one physician or provider champion, and then you'll expand that on. And that can be in any kind of delivery system. I'm going to just go here. And the last thing I wanted to address, just to give you, as you guys kind of talk about this, a thing called the concept triangle, which is a tool that I have enjoyed. And so as you guys look at process changes or have a concept about how I'm going to apply some of these cool things that I'm learning about and I'm going to take back to my practice, you come up with a change concept. So one of the things that we've struggled with in my clinic is having this tremendously expensive vaccine stock, you know. So we've got all this money invested in our refrigerator sitting right there that I would rather have other places doing other things. And so we sat down and said, how can we decrease the amount of vaccine that we have sitting here? And so we all threw around ideas. So one idea was that we only order to replace what we use that month. So great idea. So then what you do, instead of just stopping there and saying, well, let's implement that and see what we do, you really want to come back and say, well, what was the concept with this idea? And so you pull out the idea concept. So the idea is that we figure out what we need, and then we don't get overstocked by ordering too much. And so then you take the concept back to the group and say, that's a great concept. Now, what's another way we could do that concept? And so out of that comes another way we could do that would be to track what we used last year and purchase potential deficits compared to what we have in current stock. And so you can move through these as you go along, and that really helps you kind of go through and process and develop really constructive process changes that are effective in your practice as you go along. So just to kind of sum everything up, so the mindset is think like your customer for the problem that's at hand. So when you find a potential area for improvement or an opportunity to do things better around safety, effectiveness, patient-centeredness, efficiency, equity, and timeliness. So as you see those areas where something's not going as well as I think it could, really think like the customer, whether that customer is a patient, whether that customer is an end professional user, like a social worker or another nurse or another physician or a phlebotomist. So think like your customer, focus on processes, really use data, make sure that we are setting things that we're going to measure and follow those. Your map and your compass as you set out is your aim statement. What am I trying to accomplish by when? How do I know that that change is going to be an improvement? How are you going to measure it? And then what process changes can I make to result in that improvement? And then your transportation is going to be to start small, end with all. So these changes we want to expand to our whole system. Build your understanding of your processes through sequential testing. Test, implement, and spread, and then test and implement and spread. And then no can't, no bad, just opportunities and challenges as we go forward.